All right, let's dive in. We all know that feeling, right?
Yeah.
Staring at a mountain of revision notes, maybe prepping for something big like the MSRA, and just feeling, well, overwhelmed. Information overload is real.
Oh, absolutely. It's the classic challenge. You do the work, you gather the details, but figuring out what's really crucial, what's the high-yield stuff you actually need to remember. That's the trick.
Exactly. And that's what we're here to do today. We're taking your revision notes, the ones you've compiled on a specific condition, and we're going to turn them into a focused, high-impact deep dive, basically curated for you.
Think of it like we're sitting down with your notes together, pulling out the absolute essentials, the things that are most likely to stick and be useful for your revision.
So the condition we're unpacking from your notes today is pharyngeal pouch. You might also know it as Zenker's diverticulum.
Ah, Zenkers. Yeah, it's a really interesting one. Not super common, perhaps, but it has some very distinctive features that are definitely worth knowing.
Totally. So we'll stick to the structure in your notes. We'll unpack the definition, look at the causes, the risk factors, who gets it, how it actually causes problems, what else it could be confused with.
Then the clinical features, how people actually present, which is
Yeah.
super important, right? Then investigations, management options, and finally, the prognosis and potential complications.
The whole goal is to make this topic really clear and hopefully pretty memorable for your revision using your own notes as the guide.
Sounds like a plan. Let's get into it.
Okay, so starting right at the beginning,
Yeah.
according to your notes, what exactly is a pharyngeal pouch? The name kind of gives it away, a pouch near the pharynx.
It does, but the location is really specific and quite important. Your notes describe it as that pouch-like protrusion, but it forms in a very particular weak spot in the posterior pharyngeal wall.
And that specific spot has an anatomical name, doesn't it? I see it highlighted here.
It does, yeah. It develops in what's called Killian's triangle, sometimes called Killian's dehiscence. That term, Killian's triangle, is definitely one to circle in your notes.
Killian's triangle. Got it.
Yeah.
So how does it form? It's not just appearing.
No. It's basically a herniation. Your
Hmm.
notes explain it results from a weakness in the muscle lining right there. So when you swallow, there's pressure. And if that spot is weak, the inner lining can bulge outwards, forming the pouch.
Right, so a weak spot plus pressure equals an outpouching. And your notes mention the specific muscles involved at that point.
Exactly. Killian's dehiscence is that little triangular area between two muscles, the thyropharyngeus muscle and the cricopharyngeus muscle. The pouch literally herniates posteriorly right between them. Understanding that anatomy Killian's triangle between those two muscles is pretty fundamental.
Okay, makes sense. And just to hammer home the other name mentioned.
Zenker's diverticulum?
Yep.
Pharyngeal pouch, Zenker's diverticulum, same thing, same weak spot, same mechanism.
Perfect. Okay, so we know what it is, where it happens,
Meh.
which leads us naturally to well, why? Why does this weakness happen, and who's most likely to get one? What do your notes say about etiology and risk factors?
The notes describe the etiology as multifactorial, meaning there's likely more than one thing going on. It often involves age-related changes, like weakening of those pharyngeal muscles we just talked about.
Okay.
And there's often increased pressure in the pharynx during swallowing, maybe issues with the upper esophageal sphincter, not relaxing quite right. It's a combination of things.
So getting older seems like a big part of it.
Definitely. Age-related muscle changes seem key, although, interestingly, your notes do mention that the exact reason why that specific spot weakens isn't always, fully understood.
Okay. A little bit of mystery still. So, apart from just age, who are the specific people your notes flag as being at higher risk?
Right. The risk factors section paints a pretty clear picture. Older age is definitely number one. Your notes specifically say it's more common over 60 and even more common over 70.
So really thinking about the older population here.
Yes. And there's a really significant gender difference noted. It's much, much more common in males.
Older men.
Yeah,
That profile is coming through loud and clear already.
absolutely. Other factors mentioned in your notes include having a history of GERD, gastroesophageal reflux disease, also a history of chronic cough or constantly needing to clear your throat.
Right, I can imagine how the constant pressure from coughing or clearing could strain that area.
Exactly. And finally, your notes list neurological conditions that can affect swallowing, things like having had a stroke or Parkinson's disease. These can mess with the muscle coordination needed for a smooth swallow.
Okay, so if you're thinking about who might have this, picture an older man, maybe with some reflux, maybe a persistent cough, or potentially a neurological issue affecting swallowing. That really helps narrow it down.
It does, and that flows perfectly into the epidemiology section of your notes. What's the bigger picture? Where do we see this most often?
Your notes say it's relatively uncommon, say, in the UK?
That's right. It seems to be a bit more prevalent in Northern Europe, apparently.
Okay, and just a geographical note.
Yeah.
And just reinforcing those points about age and sex.
Yeah, the epidemiology data really underlines those risk factors. It primarily affects people over 70. So while risk increases over 60, it's really concentrated in that 70-plus age group. And that male-to-female ratio is striking your notes, quote, 5-to-1.
Wow, 5-to-1 male. That's a huge difference. So definitely keep older man over 70 in mind as the classic picture.
Exactly. That's a key takeaway. So we've talked about the why and the who. Let's get into the how. How does this pouch actually cause symptoms? What's the pathophysiology in simple terms?
Your notes seem pretty direct on this.
Yeah, they keep it straightforward. The basic mechanism is that weakness in the posterior pharyngeal wall, letting the pouch form in Killian's dehiscence. But the problem that causes symptoms isn't just the pouch existing.
It's what happens when you eat or drink.
Precisely. When someone swallows, instead of everything going smoothly down the esophagus, some of that food or liquid gets diverted and trapped inside the pouch.
Oh, okay. So it's the stuff getting stuck in the pouch that's the issue.
That's the core of it. That trapping is what directly leads to the clinical features we'll discuss next, and also the potential complications down the line. So, weak wall pouch forms, trapping symptoms, simple chain of vines.
Makes total sense. Okay, but lots of things can cause trouble swallowing or throat symptoms. So what else could this be mistaken for? What differentials are listed in your notes?
Yeah, this is important because you need to rule other things out. Your notes list several possibilities that can present similarly.
Like maybe other pouches lower down or growths?
Exactly. Esophageal diverticula, so pouches further down the esophagus, and esophageal tumors. Both can definitely cause swallowing issues. Achalasia is also listed.
Achalasia. That's where the muscle at the bottom end of the esophagus doesn't relax properly, right?
That's the one. So it causes food to get stuck trying to get into the stomach, but the feeling can sometimes mimic food getting stuck higher up. Reflux disease, GERD, is also there, which we already saw as a risk factor. But GERD itself can cause that lump in the throat feeling or dysphagia.
And the last one mentioned is laryngeal disorders.
Right. Problems actually originating in the voice box area can sometimes cause throat discomfort or issues related to swallowing, too.
So the main point with differentials is,
Yeah.
if someone has dysphagia or a lump feeling, you need to consider these other causes until you've specifically identified the pouch.
Exactly. They can all present with overlapping symptoms, so careful assessment is crucial.
Okay, crucial to differentiate. Now, this is where it gets really practical and honestly, probably the highest yield bit for exams or clinic. How does someone with a pharyngeal pouch actually present? What are those classic clinical features in your notes?
Well, first, always keep that typical patient profile in mind.
Older man.
Yep. And remember that anatomy herniating between the thyropharyngeus and cricopharyngeus. That location is key. Now, your notes mention a physical sign that's pretty unique. Ah, yes, the gurgling lump. It mentions you might feel a midline neck lump, especially if the pouch is big. But the really classic sign, almost pathognomonic, is that the lump might gurgle when you palpate it.
It gurgles. That's unforgettable. Why does it do that?
It's literally the sound of trapped air, food, and liquid squishing around inside that pouch when you press on it. If you feel a midline neck lump that gurgles, pharyngeal pouch should be right at the top of your list.
Okay, the gurgling lump check. Beyond that, what symptoms will the patient typically complain about?
Top of the list is usually dysphagia, difficulty swallowing. Often they notice it more with solid foods first.
Standard dysphagia, okay.
Yeah.
But there's a type of regurgitation mentioned that sounds really specific to this.
Absolutely. Regurgitation of undigested food. This is such a key differentiator. It's not like vomiting stomach contents. Because the food's stuck in the pouch above the main esophagus, it hasn't really been digested yet when it comes back up. Patients might say they bring up food from hours ago that looks, well, exactly the same.
That makes complete sense. It's trapped before digestion really starts. What else?
A feeling of a lump in the throat or something stuck in the neck. Globus sensation. Again, logical given there's literally a pouch there. Halitosis, persistent bad breath, is also common.
Because food's just sitting there decaying in the pouch.
Oh, pretty much. Like forgotten leftovers. Chronic cough or throat clearing are also frequent, maybe from tiny bits irritating the airway. And remember, that can also be a risk factor leading to it. Finally, in more advanced cases, if swallowing is really difficult or there's aspiration, weight loss can be a feature.
Okay, so let's paint the picture. Older man, difficulty swallowing solids, bringing up undigested food hours later, maybe complains of bad breath or a lump feeling, and if you're lucky, you might feel that gurgling neck lump. That's a great summary.
That's the classic consolation to remember, definitely.
Right. So you suspect it based on this picture. How do you confirm it? What investigations are key according to your notes?
Your notes are clear on the primary investigation, the gold standard test.
Has to be the barium swallow study.
Correct. It's a dynamic X-ray fluoroscopy. The patient swallows barium contrast, and you watch it go down in real time. It's brilliant for actually seeing the pouch as the barium fills it, showing its size and location, and how swallowing is working or not working.
You literally see the barium track down and then detour into this little pocket.
Exactly. It usually clinches the diagnosis. Your notes also mention a secondary investigation, though.
Upper GI endoscopy.
Yes. So while the barium swallow finds the pouch, the endoscopy is important for a couple of reasons. First, it lets you look directly inside the pouch, see its lining, the entrance. And second, really importantly, it helps rule out those other differential diagnoses like an esophageal tumor or stricture that might be causing similar symptoms or even hiding nearby.
So barium swallow to spot the pouch, endoscopy to inspect it and check the surroundings.
That's a pretty good way to summarize their roles, yeah.
Okay, diagnosis confirmed. What do we do about it? What are the management options outlined in your notes?
Your notes start with conservative measures. These are usually for people with very mild symptoms, or maybe just as a first step.
Things like changing diet, swallowing exercises, and treating GERD if it's there.
Right. Simple stuff, maybe softer foods, seeing a speech therapist for swallowing techniques, and using PPIs, proton pump inhibitors if they also have reflux.
But for many people, especially with bothersome symptoms or a bigger pouch, surgery is often needed.
That's right. And your notes mention the choice of surgery often depends on how big the pouch is. There's also a note about how practice has maybe shifted a bit over time.
Yeah, a trend towards cricopharyngeal myotomy, cutting that muscle band being more central rather than just cutting out the pouch.
Exactly, focusing on relieving that pressure point. And modern techniques often favor minimally invasive approaches.
Going in with a scope through the mouth.
Precisely. Endoscopic stapling devices are pretty common now, much less invasive than open neck surgery. Your notes actually detail two main surgical approaches based on pouch size.
For the larger pouches, there's diverticulectomy.
Yes, that's the more traditional open surgery where they actually excise or cut out the pouch. It involves removing the pouch, doing that cricopharyngeal myotomy, and then closing up the wall. Your notes list potential complications for this bigger operation: recurrent laryngeal nerve injury affecting the voice, surgical emphysema, mediastinitis, fistula, things you'd expect with neck surgery.
And for the smaller pouches.
That's where Dolman's procedure comes in, usually done endoscopically.
It says here it divides the hypopharyngeal bar.
Correct. It essentially divides that muscular wall formed by the cricopharyngeus, widening the opening and kind of incorporating the pouch into the main esophageal channel. Your notes highlight several advantages for Dolman's.
Shorter anesthesia time, getting back to eating sooner, shorter hospital stay, quicker recovery overall.
Yeah, pretty significant benefits, especially considering the typical older patient group.
But the notes add some important caveats about the evidence comparing these.
Yes, it mentions that good head-to-head comparative evidence is still a bit limited. Endoscopic approaches might be safer for frailer patients, but they might also have a slightly higher chance of the pouch coming back compared to open surgery.
And you always have the possibility that an endoscopic procedure might need to be converted to an open one during the operation.
Right. So the management strategy involves considering conservative options first, but often moving to surgery tailored to pouch size, endoscopic, like Dolman's often preferred for smaller ones, maybe open diverticulectomy for larger ones, balancing the lower invasiveness of endoscopy against potential recurrence rates.
That's a really clear breakdown of the treatment pathways. So looking ahead now, what's the usual outcome and what are the potential problems that could still pop up? Prognosis and complications.
Your notes are pretty positive on prognosis, saying it's generally good if managed appropriately.
That's good to hear. Getting relief from symptoms and preventing complications seem like achievable goals.
Definitely. And regular follow-up is mentioned as important, but complications can still happen either from the pouch itself if untreated, or sometimes related to the treatment.
What are the main ones listed?
Probably the most serious one mentioned is recurrent chest infections or aspiration pneumonia. That comes directly from the trapped food and liquids spilling over into the airway.
Yeah, that makes immediate sense. If stuff is pooling and coming back up, it's easy for it to go down the wrong way.
Exactly. In really bad cases, malnutrition and weight loss can happen if swallowing is severely affected. Esophageal narrowing or stricture is also listed as a possibility.
And GERD pops up again, noted both as a risk factor and the potential complication.
Yes, they seem to be linked sometimes. Rarer complications, particularly related to surgery, include perforation or significant bleeding.
And there's one final potential issue noted. Sounds quite serious, though the risk level is debated.
That's the risk of carcinoma cancer developing within the pouch itself. Your notes rightly say the actual level of risk is debated, but it's a potential long-term complication to be aware of.
Okay, so generally good outlook with treatment, but definitely need to watch out for aspiration risk, nutrition, potential strictures, and that small but serious possibility of malignancy within the pouch later on.
That sums up the key complications from your notes nicely.
Fantastic. Okay, let's try and tie this all together. A quick high-yield recap based on your notes, hitting the absolute must-knows for revision. We started with the definition. Pouch, Killian's triangle.
Between thyropharyngeus and cricopharyngeus muscles trapping food.
Leading to classic symptoms, especially in older men. Dysphagia, that key regurgitation of undigested food, maybe the gurgling lump.
Diagnosed primarily with a barium swallow backed up by endoscopy.
Managed conservatively if mild, but often needs surgery, with endoscopic options like Dolman's common for smaller pouches, focusing on myotomy.
Generally good prognosis, but aspiration pneumonia is a major complication risk to keep in mind.
So for your revision, nail the anatomy, Killian's triangle. The classic presentation, older male, undigested regurgitation, gurgle, dysphagia, the key test, barium swallow, and the basic management ideas, conservative versus surgery, Dolman's myotomy focus.
Those are definitely the core facts to take away from your notes.
Brilliant. Well, that's been a really focused deep dive into your notes on pharyngeal pouch, hitting all those key sections you laid out. Before we wrap up, here's a final thought to consider. We know dysphagia is common in older adults, and early pouch symptoms can be subtle. So how easily might this diagnosis get missed or delayed? And what could the consequences of that delay be for the patient, thinking about things like aspiration or malnutrition?
It really highlights why you need to keep it on your differential list, even if it's not the most common cause of dysphagia out there.
Absolutely. Well, thank you so much for sharing your notes and going through this deep dive on pharyngeal pouch with us.
No, thank you. It's always helpful to talk through this stuff, helps solidify the key points, especially when you're trying to revise.
We really hope this has been useful and helped make your notes on Zenker's Diverticulum even clearer and more memorable.
And wishing you all the very best with your MSRA prep.
Yeah, absolutely. And as you continue studying, don't forget to check out resources like pastmsra.com and freemsra.com. They've got loads of helpful material.
Definitely worth a look. Until the next deep dive.